This is Alex Otto at the Women's and Pediatric Dermatology Seminar in Newport Beach, California. It's important to check discoid patients for systemic disease. Dr. Ruth Ann Vleugels told us how she does it.
So if I see a new patient who has discoid lupus and they come to me and they've had discoid lupus for quite some time and they have a documented negative ANA, then I don't need to do repeat autoantibody studies, but I do follow them for end organ damage. And what I mean by that is, in particular, the kidneys, so I need to check renal function, I need to check a urinalysis, and I also want to check them for cytopenia, so I always check a CBC. And in a patient who comes to me and hasn't had any workup or has some signs of systemic disease, I will want to actually do a more aggressive workup, including autoantibody studies. So if the ANA is positive, we tend to also check a Smith, which is more specific for lupus, a double-stranded DNA, and complement levels to assess for kidney disease. And often we check a Rho and a La as well, although everything is a little bit different depending on the particular patient.
At 6 months follow-up, what do you check for, doctor?
So if the initial screen for systemic involvement is negative, we typically recheck labs about every 6 to 12 months. And typically at those times, we don't need to recheck autoantibody titers. Really what we want to again check is for end organ damage. So at the 6-month follow-up, the 12-month follow-up, what I'll screen for again is that renal involvement with cytopenias. So we'll check a urinalysis, renal function, and a CBC. And the reason why we're doing these investigations is because between 5 and maybe up to about 20% of our discoid lupus patients can develop systemic disease. And in one study, which was actually done at the Mayo, the risk of developing SLE, the mean time was actually up to even 8 years. So some of our discoid lupus patients don't necessarily develop signs of systemic involvement early on, but perhaps many years down the line.
So can you speak to the ANA issue, how you use ANA to guide your treatment?
So if the patient comes in and the ANA is completely negative, we can essentially tell them with near complete confidence that they don't have systemic involvement of their lupus. If the ANA is fairly low titer, particularly below 1 to 160, that ANA is typically considered not an ANA titer that would be as suggestive of systemic involvement. However, ANAs above 1 to 160 are when we're really starting to worry that that ANA titer could represent a true ANA titer that we would be concerned about in a particular patient. And in that particular patient, I would want to check the other serologies that we mentioned. And if any of them were suggestive of systemic involvement, or if their review of systems at their visit suggested any systemic involvement, in a patient with skin disease, I'd be more willing to treat them with an oral agent such as hydroxychloroquine, because there is some data to suggest that the antimalarials, including hydroxychloroquine, are disease modifying. And if the patient is placed on that, over time, if they develop systemic involvement, their SLE disease is less severe.
Would you ever repeat the large serology panel again?
So it's rare that we repeat the large serology panel in a patient who has skin-only lupus. So it's very frequent in a systemic lupus patient to follow the autoantibodies, as well as complement levels, as well as the double-stranded DNA in particular in a patient with kidney disease. But in a discoid lupus patient, if they have no signs of end organ damage and no change on the review of systems, we actually don't care if their ANA titer changes or fluctuates, because it doesn't make us treat the patient any differently. So in that particular case, I wouldn't actually recheck their serologies because it wouldn't impact my treatment.